Lijo and I are from Nigeria. It's my pleasure to invite the next speaker, by name Dr. Martijin Boomsma, who is speaking for the second time on considerations on treatment progression of MR-guided uterine fibroids for the monitoring of uterine fibroid using the IVIM analysis model. Thank you, you're welcome.
Thank you very much. Yeah, this title is very long, sorry for that, but it covers the story. First of all, I would like to thank my PhD student Loes Knorre for all her dedicated work. Without her, I wouldn't be here. And it's a funny story, but last week my senior research scientist said to me, Martin, there's something strange going on here. I said, what's the problem? He said, we only have women doing research here. There are no men left in the room. I said, okay, is this a problem? Anyway, they're all brilliant people and I'm very happy to work with them, but I think a balance is all right. So now we found some additional male PhD students. Anyway, we talk about MR HIFU, and MR is a unique way of visualizing the tissue or monitoring what's actually happening. And there's so much more in there's so much more information in MR imaging than just the pictures we see here all the time. You could do more advanced MRI technology research in this, and one of this is interprocedural, intervoxel, incoherent motion EVM analysis, and I'll try to explain this for radiologists or non-radiologists in an easy manner. So we talked about HIFU. It's a convergent energy bundle that heats up tissue, and in case of fibroids, space sharp on their belly in the MR machine. We can have excellent positioning, excellent temperature monitoring. It's absolutely superior to anything that's out there. But we are a little bit blind, as I mentioned earlier, whether or not we will be successful in heating up the tissue. And there's another thing that's a problem. While you're busy treating a patient with sonications, we don't really know directly if the sonication has been successful. We know it indirectly because of the lethal thermal dose, or we get an indication how quickly the lesion was made, but only after the procedure. By administrating intravenous gadolinium, we really know what has happened. So we really need something peri-procedural during the procedure to know what's going on. So, because sometimes we have the feeling that instead of treating a patient for 2.5 or 3 hours, we could have done this in 45 minutes. But we're not sure, so we keep on ablating. So what did we do? I'll explain later. But so if you see the upper row here, that you have several sonications and you don't really know when you're done until you're ready, and you have 100% total vascular occlusion. But in the second scenario on the lower row, you also have done many sonifications without really knowing what you were doing, and suddenly you are confronted that you only have ablated 12% of the uterus, and that's not a good result. Of the fibroid, and that's not a good result. That's insufficient. So what is IVIM analysis actually? It's an alternative to gadolinium. It's a diffusion-weighted imaging technique in which you divide D fraction, E fraction, and you have a total signal decay and a slow decay that is indicative of diffusion, and a fast decay that is indicative of perfusion. So, and this is very interesting because if we can follow up by diffusion the fast decay, the perfusion component of the diffusion, which is a netto signal, we might be able to see whether or not ablation has already occurred in the fibroid. So, so we already correlated NPV after the treatment by assessing with gadolinium with IVIM analysis in a previous paper. But we now went prospectively over time with new patients in a structured manner that we actually at several time points, T0, T45 minutes, 90 minutes, and then in the end of the treatment to do diffusion, to do IVM analysis and correlate this finally with the results. So IVM mapping, it's physics actually, and there's also some mathematics here. So you can make this better by T2 uncorrected, least square fitting. Segmentation is an issue, but yeah, issues can be resolved. And of course, how do we real time also get these analysis back from into the treatment system? So this is all research still. It's not implemented in any machine. So anyway, if you, for example, make your segmentation a bit smaller, you get less erosion, right? So these are all choices you can make, and this will be investigated with a new PhD student over the next 4 years. So we included 14 patients prospectively from the MyChoice trial. Maybe you've heard about it. The MyChoice trial is a prospective RCT between MR-HIFU treatment for fibroids and all the other treatments. And I will show you some. Yeah, you get a premiere actually. It's not been shown before anywhere on this globe, but the first time now in Cairo, of a failed treatment, a sufficient treatment, partial total vessel ablation, and total vessel ablation. Here we go. So these images are not very easy to interpret, but yeah, for your first-time reader, I've looked at them more often. Time zero, over time. There seems to be happening something over here at the end, a little bit darker. And if you look at the percentage reduction in mean F value, you see a reduction, but it was only little, and it corresponds with a non-sufficient heating of the fibroid. Here's a case of sufficient ablation. You always have to correlate with the first IVM map that has been made. And if you look at this one, where it's black, more bluish and blackish, you absolutely see a difference. But you actually see it already happening here. And is there really a difference here? Is this difference really different from this one? And now take a look. The percentage reduction of the mean F value. Only after 45 minutes, we were almost already there, and we reached the plateau. So we went on for 100 and I cannot look, 125 minutes or even longer, but it was useless. We were busy doing nothing actually. So we think this is a very promising tool to shorten treatment times. And this is important, people, because not many places on earth are women being treated with MR-HIFU. There are more patients being treated with ultrasound HIFU than with MR-HIFU. And if we want to give this technique a chance, we really have to improve techniques and also the collaboration with the industry to let these research results land in the new equipment. Okay, so I like to talk about partial total vascular occlusion because if you do a direct ablation, you heat up the tissue, you get necrosis, of course it's devascularized. But sometimes you get lucky. Or, yeah, as Tiger Woods says, the more you practice, the luckier you get. But if you can target certain vessels and occlude them, the whole fibroid is actually devascularized. And, but sometimes you have partial, that only a few vessels were completely devascularized, and the other part of the fibroid was actually direct ablated. So let's take a look at this one. This is the neutral pre-treatment value, the F factor, and this is actually the final T3. Now you see absolute difference, but is there a big difference between this one? Is there a big difference between this one and this one? Let's look at the graphs. After 45 minutes, you will already almost there, instead of 125 minutes, right? So this will be a huge game changer if we can actually predict this better, so we can shorten treatment times. And I'm sure also, if we work close with gynecology, we look at the microvascular of ultrasound. This will be a new research project. If we combine the ultrasound microvascular technology and the multiparametric MRI and IFM analysis, I think we will be very effective. So you see here that there was almost total vessel occlusion. The smooth borders over here, but look here on the back side. Some cloudish vital remnants of the fibroid remained. Okay, let's take a look at this one. You're experts now, right? You're more expert than anyone else in the world because nobody has seen them before except people in our research group. So this is the neutral state before treatment. Bluish, more black, bluish. And what we see here, total vascular occlusion. The whole fibroid is devascularized. We went on for 125 minutes, but also here at 45 minutes, we were already there. So I thought these data were I was really happy to see this data because I think it might be a game changer for MR-HIFU. Anyway, so the conclusion. I've shown you the first time intraprocedural visualization of MR-HIFU treatment using IFM analysis prospectively. I think that IFM is a promising tool in the intraprocedural evaluation of treatment progression as it shows different patterns. It can also give you a hint about failed treatment or total ablation. All right, there are limitations, small number of patients, temperature correction, better diffusion protocols. There's a lot to be done in this field to gain more more effectiveness. So we need more patients. Maybe we can collaborate with Egypt. We need to define cutoff values. That's important, and also for screening. And we have to use more data to create real-time clinical usable visualization of treatment progression. That means you have to integrate this kind of analysis in the workflow in your hospital, from the treatment console to the PACS and return, etc., etc. Thank you very much.